Okay. Because it would have been impossible. Yeah, that's presentation. Everybody is. You did.
Good morning. Nice to see you. Sam, how are you?
Good. See?
Yeah.
Yeah, we gotta spend some money today. Back, I think it was back in 2008. My students good. Someone's on the third floor, but statue. 70 was on the other. I walked up to the bed, so dude, we gotta compromise already. You guys are ratio. You guys can put a weight limit. They all laugh. It was a different time.
A lot of laughing going on today. All right, I gotta go sit down. See you later.
Good morning, everyone. Good morning. Good morning, everyone. This is the meeting of the Market Oversight and Transparency Committee. So I'm pleased to welcome people here today. I just noticed, Mr. Chairman and Mr. Seltz, that this is public meeting number 210. What a remarkable accomplishment and a tribute to transparency. So thank you for that. Our first item, we have a very full agenda today. So our first item is the minutes from our previous meeting, which was on June 13th. So I know everyone's looked through the minutes. Is there a motion to approve the minutes? Okay. I move a second to approve them. Second. Okay. All those in favor of approving the minutes? Aye. Any in opposition?
No, but I need to abstain because I wasn't here.
Okay. So all those things that we said about Wendy, hopefully we took them out of the record. So the minutes are approved. So what we want to do today is to prepare for the cost trends hearings and to address issues relevant to this particular committee as it affects the cost trends hearings, which are coming up in just 2 weeks or so. And so we're going to have first just a little bit of discussion about the hearings and the themes and the witnesses, and then one of the issues that we've been asked to look at, which we will talk about at the hearings, is on mandatory nurse staffing ratios, and so staff has been working very hard on that. So we'll hear their preliminary reports on that, get a chance to give comments before we go back and finalize that for the cost trends hearings. But first, just starting off with some of the issues and the themes and so on in the cost trends hearings. Let me turn over, David. Should I turn over to you?
Yeah, that sounds great.
Okay.
Good morning, Market Oversight and Accountability Transparency Committee, our MOAT committee, and good morning to everyone here.
and watching on the webcast. So as Chair Cutler mentioned, today we're going to focus on issues and preview for the upcoming annual cost trends hearings, which is our statutorily required responsibility to examine issues of healthcare cost growth in the Commonwealth and other timely issues impacting our healthcare market and delivery system. I would note we're pleased to be joined today by members from the full board, Undersecretary Peters and Chair Altman joining this committee for this conversation today. Before we dive into the cost trends hearings, I do just want to give a very brief program update on our registration of provider organizations program and just a public service announcement that our 2017 data set from this collection of information around the main provider organizations in Massachusetts, which is a public data set, is available online on our website, and there are master files available for download and request, and we do have including physician rosters of all the provider organizations. We're working on the 2018 filing right now, and have collected that information, are analyzing that information. That will be public soon, and are also working on what is going to be the requirements for the next year of collection through this program. So we're going to have a public comment period process coming soon on that, but wanted to at least let people know where we are with this program and what data sources are available. So with that, moving into the cost trends hearing. So we're very excited to host our 6th annual cost trends hearings coming up in 2 weeks, a little less than 2 weeks. And as a part of our annual process for the cost trends hearings, we are required under statute to seek testimony from a broad, diverse set of healthcare stakeholders in our market. Hospitals, health systems, community health centers, physician practices, as well as health plans. And as part of that process, we ask a broad spectrum of these different organizations to submit testimony to the Health Policy Commission, written testimony, in advance of the cost trends hearings. This testimony is submitted to the HPC under the pains and penalties of perjury. And this, what we call a pre-file testimony, provides an opportunity for us to be able to better prepare for the cost trends hearings and identifying what issues are really top of mind for the healthcare marketplace. So this year, we did do this process again, and we have collected pre-file testimony from 35 different healthcare providers and 14 different healthcare plans. We sought responses on a number of different issues in healthcare, including what are some of the top concerns that these organizations have for the state's ability to meet the healthcare cost growth benchmark in the future, as well as what are some of the strategies that different organizations are pursuing in order to increase the value and efficiency in our healthcare system. And finally, what are some policy recommendations that organizations have for the HPC or the Commonwealth generally that would help advance our broader goals. This year, we also asked about, for providers, we asked about the growth in urgent care centers and alternative care settings, asking questions about what types of populations and patients are being served by these new emerging models. We also asked about organizations' efforts to address social determinants of health or health-related social needs and some of the strategies and barriers they're putting in place there. On the health plan side, we also have a number of questions asking about the role of pharmacy benefit managers in helping to control healthcare or pharmaceutical spending costs, as well as some other questions around some of the cost drivers that health plans are facing in terms of rising premiums. All of this testimony is public and it is available on our website for everyone to be able to go and look and see what different organizations responded to a whole set of different questions. And as I said, as part of this process and part of the cost trends hearings, we do analyze all of these responses and start to pull out some major themes to help us think about the best framing for the cost trends hearings itself. So just to give you a preview of some of that analysis on the bottom of this slide, we did ask all of the respondents, what are your top concerns for the Commonwealth's ability to meet the healthcare cost growth benchmark? And these were the top 4 responses that we received from our respondents. Rising pharmaceutical costs, mandated nurse staffing ratios, provider price variation, and lack of access to behavioral health care. I would note among health plans, the #1 response was rising pharmaceutical costs, and among providers, the #1 concern was mandated nurse staffing ratios. In both of those categories, a majority of all respondents did identify that as an area of further examination. And as the Deputy Executive Director, Colleen Elstemeyer, will show in just a minute, we have thought about these respondents in thinking about the framing and themes for our cost trends hearings, especially on day 2, and also feeding into the research presentations you're going to hear later today on pharmacy issues and on mandated nurse staffing ratios. So with that, I'm going to turn it over to Colleen, who's just going to talk a little bit about the agenda. This is our first time announcing this publicly in terms of all of the panelists and themes and speakers. It's shaping up to be a really excellent 2 days. So turn it over to Colleen for the exciting preview.
Okay, great. Thanks, David. So on the next slide, you will see for the first time the full panelist listing for the first day of the cost trends hearing. This full agenda is now available on our website. One note about the hearing itself, we have 350 registrants and counting, so please register immediately so we can add you to that list. The registration link is also on our website. We'll also be live streaming the hearing, which will be available on our website starting both mornings. So day 1 of the hearing, not featured on this slide, we are very pleased to welcome Governor Charlie Baker and Speaker of the House Bob DeLeo to offer opening remarks to us on day 1 of the hearing. We have Dr. Ashish Jha, who will be following them with a presentation talking about putting national trends into the international context. And then kicks off our first 2 panels. As David said, these we've queued quite closely to the profile testimony responses that we did receive. So the first panel, and I won't read through the panelists on each, but the first panel will focus on strategies for meeting the healthcare cost growth benchmark in 2019. And the second panel will focus on, as you see there, witness panel 2, innovations in primary and behavioral health care, including the growth in alternative care settings, like urgent care centers, and strategies to reduce unnecessary emergency department utilization. Important to note, at the end of the first day, at approximately 3:30 p.m., we will offer opportunity for the public to testify in front of the board. The ability to testify, you'll be able to sign up the morning of the first day. So if you'd like to offer public testimony, please arrive early and get your name on the list. On day 2, similar to day 1, on Wednesday, we are very pleased to welcome Attorney General Maura Healey, who will offer the kickoff remarks on the first morning. She'll be followed by her staff, who will give a brief presentation on work that they've been, current work that they've been working on, that they want to present to the board. And then the panels on day 2 really highlight the 2 issues that we're going to be talking about today. So we have Trish Riley, who's the Executive Director of the National Academy for State Health Policy, who's going to tee it up for the first spotlight issue for us. She's going to focus on state solutions to a variety of health policy issues, including a focus on pharmaceutical drug costs and emerging cutting-edge solutions for state health policy leaders from across the country. The first panel, in reaction to Trish's presentation, Trish will also be on the panel, is focused on pharmaceutical spending growth. The next panel is focused on the topic of mandated nurse-to-patient staffing ratios, which we'll be talking about today. Preceding that panel, Dr. David Auerbach, our research director at the Health Policy Commission, will be accompanied by Dr. Joanne Spetz, who is the HPC's consultant from California. She's a professor at the Institute for Health Policy Studies at UCSF. So they will be doing a dual presentation to kick off the nurse staffing panel. So we'll have a panel featuring participants with diverse perspectives on this issue. The panel is meant to discuss the analysis as well as evidence and experience of implementing hospital nurse staffing ratios in California. We do have an RN from California who will be joining us from the California Nurses Association. And then the hearing will adjourn after that. We will not have an opportunity for public testimony on day 2, so again, just want to focus on day 1. And that's it for the hearing. Any questions on panelists or themes? Great.
Let me emphasize what Colleen said. It was more than this was not an idle issue of having Dr. Dodd speak about national and international. I mean, we rightly so focus much of our effort on the HPC about what's going on here in Massachusetts. But as I've said more than a few times, and I'll say it one more time, we occasionally have to recognize we're part of this country. And not all the trends that impact on us can be controlled by this state by itself. And so looking at national trends is important, and international trends, we often, both this country and indirectly this state, get criticized, rightly so, on a number of fronts, because when you compare the United States and therefore the state of Massachusetts to other countries, we don't look so good. But it's important to understand that, so thank you for doing that, and I just want to emphasize to everybody, this is important. It's not just a throwaway area of focusing on national issues. I'm sure you agree with me.
Over 100% if I were able to, yes. There's an enormous amount that we have to learn, that we should learn. And so I think the schedule is amazing. I think we've chosen to focus in on certain issues, which, as you said, are front and center in people's minds. And so hopefully we'll be able to guide people, give information to people so that they can make better informed decisions.
Great.
Great. So with that agenda item complete, I think we're now going to turn to 2 research presentations, which are really intended to be preview research presentations for the cost trends hearings. We're using this meeting as an opportunity to dive a little bit deeper into these issues in order to tee up a really informed conversation at the cost trends hearing. So both of these presentations are on analyses that we're releasing for the first time. And so for this committee and for others interested in comments and feedback on this work. So the first analysis that we're going to talk about today is around opportunities for enhanced transparency in consumer shopping and for certain pharmaceuticals in Massachusetts. So with that, I'm going to ask our research team to join me at the table, including our Deputy Director of Research, Sarah Sadownik, who's going to lead this part of the presentation. Again, I think this is new work and pretty exciting foray into an area that we haven't spent much time in terms of really thinking about some areas to drive more informed consumer shopping in our market that can really drive value. So with that, I'm going to turn it over to Sarah.
Great. Good morning. We're going to talk about pharmacy gag clauses and opportunity for increased price transparency for prescription drugs. Explaining the topic of pharmacy gag orders takes us to the opaque world of distribution and sales chains for drugs. A key player in this dynamic are pharmacy benefit managers, or PBMs, who administer prescription drug benefits for health insurers and act as middlemen between insurers, drug manufacturers, and pharmacies. So pharmacy gag clauses are provisions in those contracts between PBMs and pharmacies that prohibit pharmacists from telling consumers when lower cost options may be available for them to pay for prescription drugs. Some of those options could include, for example, when there are therapeutically similar drugs, that's different from a case where there's a brand and generic that are identical, but rather cases where there may be a different drug in the same category that may work in a similar fashion, but may have a much lower cost to consumers. Or the topic for today's conversation, cases where consumers' co-payment or cost insurance is actually higher than the cash price that they would pay at the pharmacy without using their insurance at all. For example, that could be the pharmacy's usual and customary retail price, or what we're calling the best cash price options through special offers or offers through discount companies such as GoodRx and Like Health. There is not much information about how prevalent these types of clauses are in the US overall, although there are a number of anecdotal examples. For example, Consumer Reports published information for consumers that included a note that Costco told Consumer Reports that pharmacists at Costco can't offer customers with Medicare a lower cash price unless the customer specifically asks, is there a better price? Now, there have been a number of states that have passed bans on pharmacy gag clauses or introduced legislation to try to do so in recent years. In the last 2 years, at least 26 states have successfully passed bans, and at least 41 state legislatures have considered such legislation. Massachusetts is among those. There were provisions that would have banned pharmacy gag clauses in the health reform bill that did not ultimately pass. Building on the movement at the state level, the federal government has recently taken action as well, with the US Senate and House passing bills in just the past few weeks to ban gag clauses in private health insurance and in Medicare. Those bills will go to President Trump for signature, and he has signaled support for this issue. So this is extremely timely in the last few weeks and hopefully upcoming few weeks. So I think this case really speaks to the power of states to take meaningful action on prescription drug issues and for individual state action to build to nationwide change. It's really a great example.
Sarah, did the Senate and House bills not include Medicaid? It was private insurance and Medicare.
The issue is the bills did pertain to private health insurance and Medicare, but the issue is most relevant to them as cost sharing is much lower for Medicaid patients. But I think we would hope that with that large of a market share, it would sort of change the market more broadly.
Sarah, the optics behind these gag clauses is pretty bad. How do the pharma companies actually defend the position?
Well, how do the drug manufacturers defend the position? Well, the drug manufacturers have often highlighted practices from PBMs that keep prices higher for consumers, and they've been a big proponent of more transparency in the PBM space. I think for exactly that reason, because they act in the space between the manufacturers and ultimately the consumers.
Yeah, I would just add to that, I think there have been instances where the pharmaceutical manufacturers have criticized these clauses because the discounts that they think that they are offering on their drugs are not necessarily making their way into the hands of the actual consumers. And that some of that overpayment that is happening may be being retained by the pharmacy benefit management companies as additional revenue.
As I understand it, it's mostly an issue of the PBMs wanting to do it as opposed to the manufacturers, where the PBMs may have some rebate contingent on the volume of a particular medication that's used. And so they want to steer people towards that medication away from other medications.
And just to add to that, Ron, were you also asking, how do the PBMs justify this? So So Sarah, maybe that's a little bit easier to answer.
Well, so PBMs have asserted that the practice is rare. Again, there are sort of no public estimates, and also have I think highlighted overall. Well, PBM's role are to keep costs low and to get the best deal, and the best vehicle to those negotiations are preference for certain drugs over others, and the volume that they're able to provide. So perhaps justification would fall along those lines, that this is where we want to keep our customers, we want to increase our volume, and in terms of keeping information about therapeutically similar drugs, well, we want to preserve volume for the drugs that have given us the best deal, and we can do that by excluding others.
So Sarah, I don't, other states, as you said, are banning it. So as I think about this issue, I could make a case, not a very good one, that says, well, pharmacists shouldn't be in there directing you away from what your doctor ordered and stuff like that. On the other hand, we have very strict consumer laws that say that if you go into whether it's a pharmacy or a supermarket, they have to have clear pricing sitting there telling you that if you buy the price of this particular cereal is X and somebody else's cereal is Y. Yes. And what you're saying, particularly when you're talking about somebody who buys with insurance, they pay $20 and you can buy the drug without the insurance for $10. There needs to be, if the pharmacy could say nothing, they should have a big sign. These are the drugs, this is what you pay with your insurance, this is what you pay. And it's very consistent with what we require every retail outlet to provide. So I'm wondering whether other states, it's one thing to ban the gag rule, but I think we should even think about going further in terms of what's available so that somebody walking up to the counter can see the relative prices, which is what we ask for everything.
I mean, that's certainly a very important consideration. And in fact, there are states. There's at least one state, Florida, that has required proactive disclosure of some information.
That's what I'm talking about, not just the pharmacist sitting back there and saying, oh, by the way, because a lot of times they don't even talk to the pharmacist. You just go and pay for your drug. They don't want to be. So anyway, I'd be curious, as you look further into this, that you make available where you can, what other states have actually done. I'm sort of withdrawn in a way. Sure, people can justify practically anything that's going on. But in this case, I would think we already have on the books laws that require pricing available to consumers, that require retail outlets to make it available. So this is a pretty shocking issue.
Absolutely. And just to run through some additional points, even through our pre-filed testimony, we did find that not only did all of the respondents note that they don't have policies that restrict information, although while that's positive, of course, there could be nuances in the questions or the answers that don't reflect all nuances of these policies. But some payers did also note that they use automatic algorithms to help consumers get the best deal, but we certainly want to build on more proactive proposals in other states. And even without, even with the best, even without outright restrictions, with the best information, arming consumers with tools to shop around and have the most transparency at their disposal is something that we're extremely interested in, and is the real focus for our analysis that we'll present. So to walk through our methodology, We compared patient cost sharing and allowed amount from the All Payer Claims database using 2015 data with the best cash prices without insurance from one prominent online shopping tool. We used GoodRx. There are others. We chose this one because we felt that the comprehensiveness of their data online was the best for our purposes. We chose the lowest price that a consumer could pay at a pharmacy in their area without insurance. That is the lesser of the pharmacy's own retail price, or a deal between GoodRx and the pharmacy. Our analysis is a very limited sample, and I want to highlight that. Of course, using the APCD, we have only the top 3 commercial payers that represent about 80% of covered lives. We looked at the top 10 prescription drugs by volume based on a recent CHEER report, and for each of those top 10 drugs, we took the most frequent combination of dose and quantity. All of these top 10 drugs by volume all happen to be generics, and these are predominantly low-priced generics. So in total, our claims that are included in our sample represent about 6% of all pharmacy claims in APCD for that year.
I asked a question about the data.
Sure.
So I had read with regards to Blink Health and not GoodRx, that they were losing a lot of their contracts in terms with the pharmacies, so that their data isn't quite as good. Did you see that reflected with GoodRx?
Well, we actually, this might help. This is a screenshot from GoodRx that might help walk through the data that is available. I guess it would be harder to know what's not available, but for this case, this is for simvastatin, for a generic cholesterol drug for a given prescription. These are prices by pharmacy in our zip code. We have the best cash price for each pharmacy. So at the top, there's Walmart. This is their regular $4 generics. I promise this presentation is not intended to be an advertisement for Walmart. And then for each pharmacy, they have in gray their cash price. There's the cash price if you walked in and said, I don't have insurance. And then the price next to it in black reflects a deal between GoodRx and that pharmacy that results in an even lower price. To access that, you need to have this sort of a GoodRx coupon. I want to stress that this is completely separate from the topic of drug manufacturer coupons. This isn't really a discount coupon type of thing, but more of sort of proof of accessing the GoodRx fund, the deal that GoodRx found. So for our analysis, from that sort of column of black numbers, we took for each drug the lowest price available at any pharmacy in the area. And if you have any additional questions, we can talk. So, so with that background, I'm going to now turn this over to Yua Wang to talk about our findings.
So this slide.
Can you hear me now? Okay. So this slide breaks down overpayments for the top 10 most prescribed drugs in Massachusetts. The total height of the bar represents the average patient cost sharing. The blue bar represents the best cash price for each one of these drugs. And that leaves the difference in orange, which represents the average overpayment for consumers who overpaid. So we can look at the first bar as an example. For the most common version of lisinopril, consumers on average paid $6.28 out of pocket, but if they had shopped around, they could have found that the best cash price was $4, and that leaves the average overpayment to be $2.28. We can see that across drugs, the average overpayments are relatively small, ranging from $2 to $5 per prescription. And below the bars, we have the pie chart, which shows the share of claims where consumers paid more than the best cash price. We can see that these shares are quite large for a lot of these drugs. In particular, the second drug, levothyroxine, which is a common thyroid medication, nearly everyone, in more than 96% of the claims, consumers paid more than the best cash price. And even though on average the overpayments are small in terms of dollar amounts, we see that some consumers are overpaying by a significant amount. Here are two examples of the distribution of the overpayments. So the gray portion on the pill bottle represents the claims where consumers did not overpay, and the rest represents claims where consumers paid more than the best cash price. So on the left, we have 30 tablets of 20 milligrams of sevastatin. We can see that in 30% of the claims, consumers did not pay more than the best cash price, which is $4. In 38% of the claims, consumers overpaid by $5 or less. However, in 25% of the claims, consumers overpaid by $5 to $10, and in more than 6% of the claims, consumers overpaid by $10 or more. And on the right, we have 30 tablets of 40 milligrams of atorvastatin. There is a larger share of claims where consumers did not overpay, but still a tail end of consumers who overpaid by a lot. For example, in 2% of the claims, consumers overpaid by $15 or more per prescription. And all these overpayments add up. Here's a breakdown of the total consumer overpayments by drug. I want to stress that even though we looked at a very limited sample of drugs, the total overpayments amounted to almost $2 million.
So to sum up our results, we found that if consumers who had overpaid had gotten the best cash price instead, the consumer payments would be 27% less. And total spending, that is both the consumer payments and insurer payments, would be 36% less. Further research is certainly needed on the wider drug market and types of drugs that we didn't look at. For example, branded or more expensive generic drugs may have different trends. We would expect that in those cases, overpayments are likely less common, but dollar amounts for those cases are likely much greater. For example, we pulled the case of generic Abilify and found the average overpayment was $27. So we certainly plan to continue our research with a wider selection of drugs, but even with our preliminary results that we presented here, these results illustrate potential opportunities for savings through greater transparency, and even with likely federal action, increasing consumer access to information and tools for comparing prescription drug prices can improve affordability for consumers and reduce total healthcare spending. Happy to take any additional questions.
Sarah, just a clarification. On slide 20, the data you presented for a 1 month supply of pills. On slide 21, where the total potential overpayments are about $2 million, is that over a year time? What's the time period for that?
It would be 1 year.
It would be 1 year. Okay, thank you.
So I think this is fascinating. I just want to put one qualification that then suggests how these results might be, whom they might be super useful or things we can suggest. The one qualification is that across these different suppliers, money is not the only difference between them. They differ in convenience and transportation and all of that. So I could very well decide I'm willing to pay more than the minimum for a store that's more convenient or that I go to for other things or for whatever reason it is. So there are all the time that people choose to go to places that are more expensive than other places because there's an additional value to them for doing so. So I wouldn't want to say that this is all, the language is important here, and overpayment is a generic description. I wouldn't want to get into the normative, therefore people are obviously doing poorly, because they're not obviously doing poorly.
Sure, certainly that's true, and I think if consumers have that information, they're making an informed choice, then that's their choice, as with any other.
Right. So that's where I was going
service.
with this. That's where I was going with this, which is that I think the group that might find this of most important would be the insurers, or or the PBMs who might say, gee, look, I've got a way that I can help consumers who really care about money, help them out, maybe by pointing out to them where they can get their medications cheaper, or how they might be able to access them cheaper, so that one of the commercial insurers or the Medicare Advantage insurers could say, look, we've got something for you. We see that this is where you're getting your medications. We'd just like to let you know if you did this or went to this store, which is also nearby, you could get them for cheaper. And that's, I think, that I think would be a quite valuable thing. Maybe if we bring some of this to the attention of the insurers, they may choose to act in a way that's not, in a way that's hard to know otherwise what to do about.
It may be a difficult messaging point to say, if you don't use your insurance at all, it would be cheaper, but.
Yeah, in this case, these are without insurance.
That's right. These reflect the best cash price without
That's
insurance.
cash price without insurance.
And
Some of
they
these have
are,
a
they are
copay
cases
price?
where the patient cost sharing with their insurance was greater than the price that they could have paid if they didn't have their insurance at all.
I see, so it might be even better for the insurer though, because then there's no claim on the insurer's part.
Exactly, which why, in this
So-
case,
so
was
even-
why the total savings
Would be
was
even,
greater than
would
the
be even
savings.
greater, so they really ought to have, pushing them to pass this along could be in everyone's interest.
Great.
Do you have any insight into, there's a lot of variation, there's a lot of variation on slide 19, on the share of claim where consumers overpaid. Any insight into why this varies so much?
Systematically, I'm not systematically. I'm not sure. It's a good question.
Yeah, I would say that for most of these drugs, we looked at the most common version, so they're mostly 30 tablets of a particular drug. And I think that these good cash deals are often offered for these very common versions. So if we looked at the wider drug markets, looking at 60 tablets or 90 tablets, it might be the case that the overpayment is not occurring as frequently.
And we may want to examine this by the different health plans and see if there's any trends or differences between the top 3 plans and these trends as well.
It's a great question as we pursue the research further.
Okay, as we near the end of this particular discussion, maybe helpful to point out to the commissioners as well as to the audience, if there are additional issues that occur to people that it would be, that we could try and incorporate before the cost trends hearings, to give feedback on those soon,
Yes.
so that if there's a potential we could say, oh gee, we can look into something else if we have the time, obviously, to do it before the cost trends hearings.
Absolutely, and we'll reiterate that point in just a minute when we get to the next conversation.
Okay.
Undersecretary, did you have a question?
Just a final comment. I think that what Professor Cutler just said a moment ago really highlights the chair's comments in the beginning about transparency. Because I may choose to go to Walmart because it's more convenient, but once I get there, I don't have the information I need to know if I had walked another 10 minutes. I could have saved $10 that month. So it's a highly interactive problem and set of solutions that we need to think about.
Great. Thank you for that feedback. With that research preview, we're going to move on to our next research preview for the cost trends hearings on our analysis of the potential cost impacts of mandated nurse patients staffing ratios. I'm going to ask the team to just come up and join me at the table who's been working on this particular issue. So I can sense a great deal of interest and anticipation in this particular research presentation. And before we dive into this, I do want to make a few introductory comments. And I want to acknowledge that there have been some questions about our process for developing this analysis, and I want to be very clear and transparent about the purpose and approach in conducting this particular piece of research. So this summer, in early anticipation of the cost trends hearings, we began exploring the feasibility and availability of the necessary data for the HPC to conduct an independent, objective examination of the estimated cost impact to the nurse staffing ballot question, balancing other issues of quality and access. This is consistent with our mandate to examine timely issues impacting healthcare spending at our annual public forum. Having determined that we had some confidence in the underlying data, in August, we contracted with Dr. Joanne Spetz, who we'll hear from in a minute, who is a nationally recognized nursing workforce expert through a competitive process in order to act as an advisor and a consultant with our research team on the analysis of the mandates in California, as well as for assistance in developing our own independent analysis. I think many of you who have been following this issue know that there have been other public reports on this particular issue. Our approach to the cost estimate was developed independently from other studies, and as a result, our findings differ. Our assumptions and estimates are grounded in data and informed by credible academic literature. In the interest of transparency, we have included in the technical appendix to this presentation a very clear crosswalk that indicates the differences between what was examined and what was not examined, data sources, and the variables that build up to our estimates compared to those of some of these other public reports. We anticipate that there may be some objections to the inclusion or exclusion of certain factors, and we acknowledge throughout this presentation what those assumptions are and where we did have some significant data limitations that prevented us from fully analyzing the impacts of the potential mandated nurse staffing ratios. So today, we're going to be presenting our analysis to this committee and the public for the first time, and we're going to walk through in detail our methodology and findings. As I said at the beginning, the purpose of today's presentation is really to help tee up an informed discussion at the cost trends hearings, which Colleen noted earlier will include participants with different perspectives on the implications of a potential mandate. We fully expect that after the presentation today, there will be additional comments from interested stakeholders on this analysis, and we welcome any comments and feedback you may have. We commit to fully analyzing those comments received. We would post them to our website in order to enhance the public transparency of this issue. And if changes are warranted to our analysis, we will do our best to update these findings before October 17th. So this research presentation presented for you today is really for your feedback as well, and as we prepare for the cost trends hearings. So diving right into the presentation, this first slide overviews or goes over our oversight authority in analyzing mandated nurse staffing ratios. I've touched on many of these points already, so will not repeat myself, other than to add that the Health Policy Commission did have a role in developing the regulations for nurse staffing ratios in intensive care units a few years ago, and do have some experience working in this area, as well as we did also develop guidance for mandatory nurse overtime. That was back in 2013. So this next slide, 27, really is kind of a table of contents for the analysis that we'll be presenting here today and that we've been working on. I, again, won't walk through each of these in detail, but just to give you a preview, we will be going an overview of the proposed initiative, and its comparison to the California law. California is the only other state that has mandated nurse-patient staffing ratios. We're going to have a summary of what we know about the California's experience and some comparisons to California and Massachusetts. And then we're going to move into our cost impact analysis and talk about our methodology, as well as some of the inclusions and exclusions of different pieces that are incorporated in our analysis. We're going to talk about some potential cost savings, and then finally have a slide really teeing up a conversation at the cost trends hearings about what some of the implications of this findings may be.
David, before we dive in,
Yep.
Can I pick up on one of the points you raised, and this may be more a question for David Auerbach. Has there been any analysis of the impact of the intensive care unit staffing requirements as to either the cost or especially the impact on patients of that?
So I can actually speak to this. This was something that we did look into ourselves, and we found that the time frame of when those regulations went into effect would make it very difficult to draw conclusions from the impact of those regulations. We did have, as you may recall, a staggered kind of implementation timeline for those, and the feasibility of kind of a pre and post was not something that we felt would be credible just given the timeline. That being said, I am aware of a study that was, I think, released by a group of researchers and physicians that associated with the Beth Israel system that was released a few weeks ago. I'm looking to Lois to make sure I got that right. You know, I'd be happy to share that study with you and the commission. So, want to highlight for the committee and for the public here, we are really really grateful to have on staff at the Health Policy Commission one of our nation's leading experts in nursing workforce issues, Dr. David Auerbach. He has been published many times on these issues and is a spokesperson for these issues in his own right across the country. And he leads our research department, which led our work and analysis in this area. As I mentioned, we did want to bring in some external expert consulting support, and so we brought on Dr. Joanne Spetz. You can see her bio here, but she is, again, a leading national expert on these issues. She works out of the University of California, San Francisco, and has had many published papers on the impact of nurse staffing ratios in California. And is extremely well versed in all of the academic literature that exists on these issues, not just her own work. So really pleased to have her join the team and to be able to help provide expert advice and counsel as we conducted this work. And I would say at this point, I'm also very pleased to say that she is here today on the phone, calling in from California. I don't know what the time difference is, but I can imagine it's pretty early there, 7:30. Maybe just good morning, Dr. Spetz. Okay.
Can you hear me okay?
Yeah. Great. So she's going to be here to talk about some of the summary of experience in California, and I would note she will be with us in person at the cost trends hearings presenting. But thank you, Dr. Spetz, for waking up early to join this conversation today. I do also want to acknowledge the other members of the team that really worked on this analysis. Lois Johnson, General Counsel for the Health Policy Commission, who also led our agency's work on the ICU nurse staffing, or the ICU piece, as well as mandatory nurse overtime. Kate McCann, Assistant Counsel, and Hannah James, Research Associate on our team. So with that, I'm going to turn over the presentation to the team that's really been working on this analysis, and start with General Counsel Lois Johnson, who's going to talk a little bit about the current regulatory and legal landscape, the proposed initiative, and differences between the proposed initiative and California's.
Morning, everybody. Thank you, David. So this slide, as David said, describes the regulations and other considerations for nurse staffing in Massachusetts. As we know, in intensive care units in Massachusetts, there are patient assignment limits pursuant to the law that was passed in 2014, and just the framework of implementation there. The law was passed in 2014. We promulgated, the Health Policy Commission promulgated a regulation in 2015, and there was staggered implementation. First, academic medical centers implemented the law in 2016, and then NICUs, neonatal intensive care units, and community hospitals followed in 2017. For all other hospital units, state and federal regulations require hospitals to staff nurses at levels appropriate to the patient care needed, so a general requirement. In some cases, DPH regulations require hospitals to follow guidelines that are produced by professional clinical associations, such as the perinatal guidelines of AWON, described on this slide, and hospitals may also elect to follow similar guidelines in other instances. In addition, hospitals and the unions representing nurses may agree on specific staffing requirements through collective bargaining. In general, hospitals develop staffing plans based on their own historical patient and staff census, that's specific for each hospital. So the next few slides describe the proposed initiative to mandate staffing ratios in hospitals in Massachusetts. At a high level, the provisions of the initiative are summarized, and they would require the specific ratios described here at all times in different types of units. Other provisions of the initiative include required implementation plans for each hospital, the development and implementation of acuity tools to assess patient stability, and notice requirements and enforcement provisions. So in the next few slides, I will summarize and compare key differences between the Massachusetts proposed initiative and California's law and regulations. As we stated, California is the only state in the country that mandates nurse staffing ratios in hospital units. That law was passed in 1999, and regulations were finalized in 2004. So some key differences include the regulation and implementation provisions. In California, the statute didn't specify the specific ratios for each unit, but instead directed the California Department of Health Services to establish them by regulation, which occurred through a public regulation development process over time and took a period of years. In contrast, the Massachusetts proposal specifies the ratios for each unit. There are differences in the specific ratios in effect in California and those proposed in Massachusetts, and in many cases, those proposed for Massachusetts are more strict. So for example, California requires a 1 nurse to 5 patient ratio for medical surgical units, and the proposed ratio in Massachusetts for those units would be 1 to 4. California requires a ratio of 1 to 6 for psychiatric units, and the proposed ratio here would be 1 to 5. In addition, in California, hospitals can use other licensed staff, such as licensed vocational nurses, or in psych units, psychiatric techs, to constitute up to 50% of the staffing requirements, while the proposed initiative in Massachusetts does not include such a provision. The Massachusetts proposal prohibits any reduction in healthcare workforce staffing levels as a result of implementation of the RN patient assignment limits, and that is not included in the California law. In addition, no waivers would be allowed in Massachusetts, while in California, flexibility must be considered for rural hospitals. In Massachusetts, the requirements could only be suspended in the case of a state or national public health emergency, while in California, the definition of healthcare emergency is broader. And the enforcement provisions in the proposed initiative in Massachusetts are stricter, including monetary penalties of up to $25,000 per violation. So with that summary and overview, I'm going to turn the presentation over to Dr. Spetz, who will describe the experience of implementing nurse staffing ratios.
Great, thank you. California has had the minimum staffing ratios in place since 2004 after a 5-year development and implementation process. In the years since then, there have been a number of studies that have been published on the impact of the law. And I think that there are 4 key takeaways of the experience in California. One is that there was a significant increase in nurse staffing in California hospitals after implementation of the ratios, and I'll detail all of these 4 main takeaways in a moment. There was a moderate effect on RN wages post-implementation of ratios. There evidence, I would say, suggests no systematic improvement in patient outcomes or the outcomes we've been able to measure after implementation of the ratios. And there were no comprehensive retrospective analyses of the cost of the implementation in California or any cost-benefit analyses. So I'll provide some details about these takeaways, which are drawn from the published literature. Starting on the next slide with the increase in nurse staffing in California hospitals after the implementation of the ratios, there were a number of different studies that analyzed various aspects of the ratios, and they found that the average number of nursing productive hours and ratios in medical surgical nurses in particular increased markedly. Those studies have primarily used data from the California Office of Statewide Health Planning and Development, which, unlike your patient care link data, does not provide data at the kind of shift or specific unit level. It categorizes nursing hours per patient day reported at the yearly level, and you have to do the math to come up with patient hours per patient day. It's annual and it's averaged for the full year across all units of a certain type. So we cannot talk about specifically whether one unit within a hospital increased or how much they increased versus another, or whether night shift versus day shift increased or changed differentially. One study found that the statewide average RN hours per patient day increased more than 16% over a 7-year period to reach an average of about 7 hours per patient day, with 6.9 in that study. A review of all of the studies that were conducted through 2012 reported that the average minimum reported growth in hours per patient day appeared to be about 30 minutes, and some studies reported an average increase of up to 1 hour. The growth in licensed nurse staffing was primarily the result of increases in registered nurse staffing. None of the studies found an increase in the staffing of licensed vocational nurses. This may be in part because California's licensing and scope of practice regulations around LVNs are relatively restricted compared to many other states. So it can be challenging for hospitals to heavily rely upon LVNs within acute care settings. One study suggested that there was substitution of licensed nurses for unlicensed staff, that may have occurred. Other studies have found that may not have occurred in the long term or occurred only among certain hospitals. But in general, it did look like in some data that the increase in registered nurse staffing was larger than overall staffing, which might suggest that the unlicensed personnel in some hospitals were reduced. On the second takeaway, overall, there was a moderate effect of RN wages after the implementation of the ratios. California's ratios were implemented during a period of significant nursing shortage, both in California and across the country. And labor economics would suggest that when there is an increase in the demand for some kind of a worker, that the wages for that worker will rise. So There were a number of studies, including work I did with Barbara Mark and David Harless, where researchers have looked at what the impact was on wages. In general, these studies found wage increases across all nurses that ranged anywhere from 0% to 8%, depending on the time period studied and depending on the specific data set used. Some data sets had more observations, so you could get statistical significance more easily. Other data sets had fewer observations. In general, the studies that have been done on that compared wage growth in California to wage growth in other states during the same time period, which provided essentially a control group of what was happening with wages in other states. Because as I mentioned, it was a national nursing shortage at that time. So in general, wages were rising nationwide. And we wanted to tease out exactly what the impact was in California distinct from other states. On the next slide, we identified that there is no systematic improvement in patient outcomes after the implementation of the ratios. And what I mean by no systematic improvement is that some studies found some improvement, some found no improvement, and some found differences depending on which outcome they were studying. So in general, the research that has been conducted shows us that higher levels of nurse staffing are associated with improvements in various patient outcomes. There are National Quality Forum endorsed nurse-sensitive outcome measures. There is a body of research that suggests that better nurse staffing is associated with shorter hospital stays, lower rates of failure to rescue a patient after the patient has a complication, fewer pressure ulcers, fewer hospital-acquired infections, and various other outcomes. So there's a large body of evidence, the preponderance of the literature would suggest that there is a causal relationship between better nurse staffing and better patient outcomes. There were a number of studies done looking at the impact of California staffing ratios, which really focused on the question in the better studies of does forcing hospitals to change their staffing result in better outcomes. Because the preponderance of the evidence is based on observational data where hospitals are making the decisions themselves. And that is not necessarily the same thing as saying that when hospitals under a regulation have to change their staffing, do you get the same results? So the most comprehensive analyses have generally done comparisons between California and other states and or between hospitals in California that had lower staffing prior to the ratios and therefore had to increase their staffing more due to the regulations versus hospitals that had less of an impact of the ratios on their staffing patterns. These analyses have found a variety of things. One of the best studies did find that failure to rescue rates decreased significantly more in some California hospitals than others in comparison to other states. But for other outcomes, results were mixed. Some of the studies that have been published, including ones I have co-authored and was lead author on, found that some outcomes got worse, some got better, some had no statistical significance in their change. And so taken together, I interpret the literature as a little bit of a wash. It's very hard to conclude that the California regulations systematically improved quality of patient care across all outcomes. There also has been no comprehensive retrospective analysis of the implementation costs or any attempt at making a cost-benefit analysis in California. After the passage of the law, but before the implementation of the ratios, there were two different analyses that examined the potential cost impact of different ratio proposals. The California Nurses Association, Service Employees International Union, and the California Hospital Association all made recommendations to the Department of Health Services about what they thought the ratio regulations should be. And then there were two different analyses about what the potential cost of those ratios might be. But there was no study later to see if those were what the cost actually ended up being. A later study conducted in 2012 concluded that the implementation of the ratios in California did put substantial financial pressure on many hospitals, concentrated among hospitals that were in the kind of middle two quartiles of pre-regulation staffing levels. And And then, but again, we don't really know what the end impact was overall on cost of the ratio implementation in California. And turn it back over to the team at the Health Policy Commission.
Before we go on, it might be a good time to stop for questions for Dr. Spence. No, I have one, but Wendy, why don't you go ahead and start off?
Dr. Spence, thank you for that.
Introduce yourself.
I'm Wendy Everett. Nice to meet you. Just to go back, if you could speak a little bit more on slide 36 when you were talking about the summary conclusion number 3. You mentioned that some hospitals had changed their staffing ratios on a voluntary basis, and some had done so because of the regulations and the mandates. Has anyone looked at kind of whether or not there are differences between those two classes of hospitals, and is that important? And maybe that's just an interesting variable that doesn't drive any of the conclusions, but it would seem to me to be very interesting just to understand whether or not the culture in those hospitals affected the outcomes or not.
I don't believe any studies have explicitly looked at that. In general, California, prior to implementation of these ratios, did have a regulation in place requiring that hospitals establish an acuity system to determine staffing. So there was a lot of variation in staffing, and we did see some hospitals, that had relatively rich staffing ratios, often academic medical centers, hospitals with relatively high acuity. This was a period of time where the magnet programs, I think, were just launching, so hospitals that were striving for magnet status were also, demonstrating higher staffing ratios. But, those comparisons have been done. I don't think that there really have been studies that have done a intersection between the culture within the California hospitals and then the staffing ratios and then the ultimate impact, nor have there been any related to the kind of the collective bargaining environment.
Thank you.
I too wanted to understand a little bit about the collective bargaining requirement, and in particular how California compares to Massachusetts on that dimension, and whether you would think that a highly unionized workforce would have a different wage response than a less unionized workforce in terms of the ease of substituting people or the need to raise wages for many different classes of workers. So I just be open for any thoughts on that. And my second question is, you said there were no ex post analyses of implementation costs. Do you have any informal sense about how hospitals dealt with the increase in cost? Did hospitals pursue different strategies? Did they wind up raising prices, cutting into reserves? What was the impact to the extent you can say?
Those are both great questions. I'll start with the unionization collective bargaining. That is something that we share with you. We have a fairly high penetration of unions across our hospitals, predominantly the California Nurses Association, which is closely allied with the Massachusetts Nurses Association. In some hospitals, we have other unions, and in the Kaiser system, the non-RN personnel are represented by Service Employees International Union, and they actually, as part of their labor management partnership, came to agreement about targeted staffing ratios after the ratios were passed in California, not only for registered nurses, but across all personnel. So, which was very interesting. But the data that we have available on Kaiser is not as rich in general as for other hospitals, just because of the reporting requirements being a little bit different between Kaiser and other systems. But But that is something where, you know, it's, we have a similarity there. We don't have a lot of information about on what timeline, say, wage changes might have occurred related to the ratios. But my sense is from qualitative research that we did that hospitals that did have collective bargaining agreements, that the unions often played a role in essentially holding hospitals' feet to the fire on adhering to the ratios. Shortly after the ratios were implemented, we did a study that was sponsored by the California Healthcare Foundation. The peer-reviewed journal article was led by my colleague Susan Chapman, but we all worked on all of the research, both quantitative and qualitative. And we interviewed a lot of chief nursing officers and other healthcare executives across California. What we heard about how they managed it financially was some straight out said that when they had their next round of bargaining with insurance companies for their contracts, that they stated that the minimum ratio requirements were a reason that they needed to have higher reimbursement. And that was one of the number of factors that they used in their bargaining agreements to justify increased requests for reimbursement rates. So that was one of the mechanisms that they used. We heard anecdotally from some healthcare leaders that they also were laying off or not replacing unlicensed personnel as they left their jobs. But as I said, the overall data analyses don't really demonstrate that that was a persistent or necessarily systematic thing. My guess would be it happens in some hospitals, and I do recall that that the union that represented unlicensed personnel actually filed a complaint against Stanford after the ratios had been implemented, and they were alleging that Stanford was laying off unlicensed personnel due to the ratios. So, you know, anecdotally, it seems like that may have happened in some settings.
I have two more questions. Let me ask both Ron and Rick to be as brief as you can, so we can turn to David.
Thanks for joining us today. We appreciate it. In terms of patient outcomes, when we're looking at the ratios, what percentage of the institutions were already at that ratio? Were they basically the larger institutions? And were you able to look at the variance in outcomes between the institutions that actually were at that level, if any of them were, versus those that were not?
That's a great question. The nature of the data that we had in California didn't really allow us to directly say how many hospitals were meeting the ratios versus not. Because the data that we had were all reported as annual total hours of RN time per unit type and then annual patient days per unit type. We only had the average. And we did do some survey work and found variations that are very similar to the patient care link data where night shifts tended to be staffed less richly than day shifts and so on. So the studies that have been done, generally the studies that I did as well as, if I recall correctly, the work done by Cook and Gaynor, we categorized hospitals by their quartile of pre-ratio average annual hours per patient day by unit type. So we did that by medical surgical units because those are the largest component of hospital care. And then we looked at those quartiles for changes in staffing. In general, hospitals that were in the top quartile really didn't make any changes to their staffing. You don't see a lot of action there. You see the action in the hospitals that are in the lower quartiles of staffing. And the pattern generally follows exactly what you'd expect. The hospitals that were in the bottom two quartiles of pre-ratio regulation staffing had the biggest increases. We then used that as a mechanism of looking at whether there were outcomes changes for patient safety indicators and other patient outcomes indicators, and did not find that the change in staffing was systematically associated with changes in patient outcomes. Some got better, some got worse, a lot were not statistically significant. The results varied by whether you were looking only at California and comparing the kind of no change versus lots of change hospitals versus doing a comparison also across other states. So the results are pretty mixed. There was one cross-sectional paper that was published with the lead author being Linda Aiken that in a single year of data demonstrated an association between nurse staffing and patient outcomes. They were comparing California, New Jersey, and Pennsylvania hospitals and, made the statement that these data suggested that there were quality changes or quality associations with the better nurse staffing in California with outcomes, but they did not do a pre-post type of design. So they could not associate causally whether those outcomes differences were due to the ratios or due to some other factors in California.
Is it okay if I get you to hold your question?
Sure.
And then turn to David Auerbach, and then I'll give you first, right?
Okay, thank you.
All right, David.
All right, we're going to turn now to the second part of the presentation, led by Dr. David Auerbach, who's going to walk through some findings about Massachusetts and California, a background on the RN workforce in Massachusetts, and then we're going to get right into our cost impact analysis. So I recognize the time here. I hope it's okay if we go a little bit after our time, given the importance of this stuff. Okay, we'll keep moving.
Okay, thank you, David. I'll go as quickly as I can. Some of the points here are important to spend a little time to understand. Okay, this first slide. So by way of background of the nursing workforce in Massachusetts and current staffing practices, I'm just going to present a little bit of background data to level setting. Here on this graph, we're showing average staffing levels of numbers of RN full-time equivalents, FTEs, per 1,000 patient days by state. This is data from 2016. And this just shows that according to the American Hospital Association data, most recent data we have, staffing levels in Massachusetts are relatively high today, higher than the national average and somewhat above California's average. In the next couple of slides, we'll go through all of the quality measures that we had available to us to review in terms of quality measures that are sensitive to nursing sensitive. This slide is comparing a number of measures between Massachusetts' average levels and California's average levels. And these are hospital-associated infections. Okay, sure, Lori.
Clarifying question?
Yes.
Is this post-implementation data from California that's compared to?
Yes, this is all 2016 here. So post-implementation in California. Okay. Yeah, and right. So I'll just note that on this slide, these are observed infection rates compared to expected given a hospital's patient characteristics. So the lower number is better quality. And on these set of measures, Massachusetts does perform well relative to California on 5 out of the 6. And I'll note that last measure of ventilator-associated events is reported somewhat differently as a voluntary measure in Massachusetts hospitals, but it's required for California. And that could explain some of the differences in that one measure. We reviewed a number of additional nursing-sensitive patient quality measures available in the Medicare population only. And on these two, as well in Massachusetts and California, have similar rates. Pressure ulcers and falls with hip fracture on the left, and a composite on the right, which combines those plus 8 additional measures, including post-operative infection rates and other measures. And that is reported as an index where, again, all of these, the lower number is better. They're similar to California. Okay, so now I'll go over a little bit about the nursing workforce in Massachusetts. Compared to the rest of the country, we do have a large number of nurses. As you saw in the staffing data on the lower left, RNs per capita in Massachusetts are quite high compared to the rest of the country. And RN salaries are also high compared to the rest of the country. About $84,000 for a nurse on average and about $90,000 for hospital nurses. RN compensation is a large portion of hospitals' total operating costs, representing about 20%. And nurses in Massachusetts, on average, are older than in the rest of the country, with about 44% over age 50. And nurses are slightly more educated in Massachusetts, with about 68% having a bachelor's degree or higher. It's also important to understand the full array of where registered nurses work in Massachusetts. We're focusing mostly today on hospital nurses, and that top level of about 15,000 inpatient RN staff are the main focus of today's analysis, and these are the ones most directly affected by the mandate. But there are registered nurses working across a number of settings in the state, and many more of them. For example, in long-term care and in outpatient departments, in home health, and in schools and other settings as well. And the total is about 83,000 registered nurses, full-time equivalents in the state today. So with that background, now I'll go over how we came about our cost estimate and the methodology underlying it. As Joanne mentioned, the staffing data that we have available to us to do this analysis is better than they had in California. We have the benefit of Patient Care Link, which we'll refer to. It's a website where hospitals report their staffing at a very detailed level by shift for all of the units that they are able to report. And this data forms the basis of our analysis as well as many of the others that you've heard about. Here we have a list of the units that we had data available for. Important to note that we did not have, even with this data, some units in the hospital are not reported in this data set. And that's a reason why some of the hospitals or hospital units are excluded from our analysis. But for the units that we did have good data, what we were able to do was to compare the levels of staff and report the number of RNs for a given shift, from 7 to 3 p.m. and so on. And they also report the average patient census per day on that shift. Comparing the numbers of nurses to the numbers of patients, we were able to derive those ratios and compare them to the mandated levels. And that forms the basis of our core analysis. We also brought in some estimates from a number of other areas that were important for the analysis where we could. We estimated an impact on RN wages, which Joanne nicely referred to and described. It's similar to her analysis. And considered other areas for costs as well as areas for savings, some of which were included in our formal analysis and some of which we will just mention, but we did not have enough confidence to include it in the formal analysis, but we will speak to that. Okay. So this slide describes an important concept in thinking about staffing levels today and what the implication of a mandate would actually be. So I'll walk through this a little bit. What we're showing here is 10 hypothetical hospital units. And let's imagine that they're all medical surgical units with 40 patients. So shown in the blue is, for example, the number of RNs staffed for those 40 patients. And we have 10 hypothetical units here. So unit number 1 has 7 RNs. Unit number 7 has 10 RNs. Now the mandate would require that you have 1 nurse to 4 patients. So for our 40 patient units, we need 10 nurses to meet the mandated level on average. So unit 1, starting with 7 nurses, would need 3 more, as shown in the orange, to reach that mandated level of 10 nurses for the 40 patients. You can see that unit 7 already has 10 nurses. They meet the mandated level on average. And if I add up all the needed nurses in those orange bars, they add up to about 10.5 additional nurses needed across these 10 units. Okay, so that seems fairly straightforward, but what makes it complicated is that the mandate requires that units meet these patient ratios at all times. It is not good enough to have a staffing level that meets the mandate level on average. So you need additional RNs. Sometimes RNs are on a meal break, transporting a patient. Sometimes your patient census will flow up and down, and you need to cover and meet those ratios at all times. And this is an area that is not straightforward to estimate how many additional nurses I need. So for that reason, and another reason, we are going to develop our estimates in 2 scenarios that I'll describe on the next slide. But what's shown here is if I assume that I need to staff at 10% above that ratio, as in I need 11 RNs on that staff for my 40 patients rather than 10, those hashed orange bars on the top are showing the additional staffing needed to meet those mandated ratios because of the at all times requirement. And adding up those orange sections, hash sections on top adds another 8 RNs to my needed RNs. So now instead of needing 10.5, I need 18. So that's just to illustrate that what seems like a small increase I need to staff over that mandated level really increases my number of staffing needed by a large proportion. Okay? Are there any questions at this point? Because that's an important concept. This is the first slide of results. So as I described, we're doing 2 analyses and 2 scenarios, analysis A and analysis B. And what we're showing here is analysis A is going to employ that 10% assumption that units need to staff 10% over the mandate to meet the adult times requirement. Analysis B is going to employ a 20% assumption that units need to staff 20% over the mandated level. And that's reflecting the uncertainty in what that really actually should be. So, results below that, we're showing on the column on the left is without any assumption about staffing over the mandate, if staffing at the average level was adequate, we would still find that 34% of hospital units would need to increase staffing to meet the mandated level on average, representing a need of about 1,100 RNs out of our baseline of around 15,000 RN staff. That would be an 8% increase. When I employ the 10% assumption in analysis A, now there are 46% of units that are understaffed and would need to increase by about 1,800 RNs to meet the mandate. In analysis B, 54% of units would need to increase their staff to a tune of 2,600 inpatient RNs. Okay. So now I'm going to show where would those increases be distributed, because there's differences by type of unit in the hospital that are important. We can look by hospital cohort, the way CHIA breaks them down. The community high public payer hospitals are community hospitals that serve a high proportion of Medicaid and Medicare patients. They would need to increase their staffing the most. Under analysis A by 21% and under analysis B by 30%. You see the academic medical centers towards the right would have a smaller required increase. Their staffing is higher relative to the mandate currently. You can see on the bottom that required increases would vary by the type of shift. Larger increases, not surprisingly, would have to occur in the night shifts, where the staffing levels are generally lower, and that is often reflecting the lower patient acuity, but these mandates would not adjust for that. The minimums are still as they are. Okay. You can also look at the difference in required staffing by type of hospital unit. And there are some important differences here too. You see toward the left, rehab units would have to increase by a large percent. Psychiatric units would have to increase by about a third under scenario A, by 44% in scenario B. Labor and delivery units would have to increase by a large proportion. And then you see the med-surg units, which are the most abundant types of units, would have to increase by 11% RN staffing under scenario A and 18% in scenario B. And some of the units on the far right would not have to increase very much at all. Now we can distribute that in a different way. This is the entire increase of RNs needed, and here we're using the 1,800 under scenario A. Where would they be going? And you can see that almost half would be needed in those med-surg units, which are the most abundant. But about 15% would be needed in labor and delivery units, and about 18% in psychiatric units. Okay, so that's the core estimate based on the patient care link staffing data that we have available of the number of RNs required. We also understand that there would be a large increase required in freestanding psychiatric hospitals. Though we didn't have the same level of detailed data, we had enough confidence to estimate an increase, in this case, of 477 additional RNs, given the 1:5 mandated ratio in these units. And so when we add that to the total number of needed RNs below, we have a total of 2,200 in scenario A and 3,100 in scenario B. Okay, now let's move to the cost aspect. An important feature of this estimate is, again, as Joanne mentioned, the increase in RN wages that would be expected from that level of required increases in the number of RNs needed. As Joanne noted, there's several high-quality studies that looked at the increase in wages in California compared to other states at the same time. And we used that differential, that the wages of RNs in California increased faster. And as Joanne noted, those studies were done in 5 different data sets, and the average increase was found to be roughly 4%. Now, we have reason to suspect that those increases might be larger in Massachusetts for a number of reasons. The ratios are stricter, as Lois noted. penalties are higher, and you cannot use other staff to meet these ratios. In California, you could use licensed vocational nurses and not here. So those could all push that wage effect higher. And for that reason, we employ, again, using our scenario A and scenario B, a 4% estimate in scenario A, and a 6% wage increase estimate in scenario B. And this is important because it would be felt across all RNs in the state. That is what the studies measured, so that is how we would apply it. Another important point to note, though, is that these wage increases would not take place overnight. A lot of pre-existing labor contracts, you're being paid what you're being paid, and as those turn over, those increases would kick in. Okay. So this slide is detailing the bottom line, combining those impacts that I mentioned. Under analysis A, you see the impact of hiring and full total compensation for those additional required RNs of about $256 million. You can see the wage increase for all the rest of the RNs in the state, including those RNs, amounting to about $184 million. We also estimated ongoing costs for using these acuity tools, which are required, of about $26 million. That totals roughly $460 million across acute care hospitals in the state under analysis A. And the numbers are higher as expected under analysis B. We also estimated impact separately for the psychiatric and substance use disorder hospitals. As you can see there, about $49-50 million under the two scenarios. So we estimate costs to other employers of RNs outside of the hospital who would also experience these wage increases as the demand increased for their RNs as well, between $93 and $140 million. And finally, cost of implementation at state-owned hospitals, ranging between $60 and $74 million, leading to the total of about $676 million in scenario A and $949 under scenario B. I'll note that these cost estimates are likely conservative, and I'll get to that in a little bit, because of additional units where RNs work, such as the ED, that we did not have detailed data sufficient enough for us to put a quantitative estimate to it. Yes.
Can I interrupt you for 1 second?
Please.
So I'm going to have to go in a second because while my dean appreciates that I do this, she also appreciates that I teach my class. That's why I will go in a second. Is there a way between now and the cost trends hearings that we could try to estimate the impact on the EDs as well and add them in?
It's hard to say. We will do all we can.
Okay.
Was it just a question of, since the ballot question includes emergency departments, was it just a question of time or lack of data?
Lack of data
that they aren't included?
I mean, if we could,
Okay.
sure, if we could go out and collect our own data, there's no time.
I wonder if we could just survey 2 or 3 hospitals and get their staffing in the ED, and then we could try and extrapolate something from that.
We promise we won't call it research.
We recognize this is a gap in our analysis, and it is impactful when we think about what the estimated impact may be. And there are some other issues that others have raised about the impact on emergency departments. We did run this down as best we could to try to get some confidence in the data to include it in our analysis. I agree with you, Professor Cutler. It is an area of importance for having a robust and comprehensive analysis. We will do our best to try to think about, while maybe not being able to include it here in our formal analysis, as you'll see in the next couple slides, there are some areas where we give some illustrative examples of what the potential impacts could be based on maybe some survey information.
That said, I'm going to leave it in Wendy's hands. I'm just going to give my comment, which is one to thank both Dr. Auerbach and Dr. Spetz for first-rate work, just absolutely fantastic work. So thank you a lot. And I think one of the questions we'll have to think about is, what does this mean in the Massachusetts context where we're trying to pull down the rate of spending, and where the hospitals that will be hit the most are those with high public payer patients, where not only are they not getting price increases, but holding it down even more is going to impact them even more. And we just had a discussion a week or 2 ago about what do we do about some of those organizations that feel like they're going to be formed the consolidation. And now to throw this on top of it, it seems to me we really, really have to think about that super carefully in terms of what it would mean for those organizations. And I sort of shudder to think about that, but it's clear that we're going to have that discussion at the cost trends hearings, or the Commonwealth is going to have to think about what does it mean to take those institutions serving a large number of very needy patients and imposing additional costs on those institutions when already their revenues are not increasing anywhere near as rapidly as other institutions and as they are in other states. So I'm going to stop there, and I apologize to my fellow commissioners. Wendy is going to lead the discussion in my absence.
Thank you, Professor Cutler. I think Undersecretary.
Right, well, I did, Dr. Auerbach, did you want to finish the presentation and then understanding that this is a preliminary report of the research prior to the official presentation of the cost trends hearings. We do want to have time for all the commissioners to ask questions, so we'll continue on until we've completed that. But did you have a few more slides to go through?
Sure, and I can go through them fairly quickly, but if there are clarifying questions on any given slide, I don't mind that at all.
Yeah, my question is clarifying
Sure.
in nature.
Sure.
It is, so I know that this does not include ED units. But are there other hospital types that are not included in this cost estimate?
These include most of the hospital types there. I'll get to on the next slide. There is a little bit of uncertainty as to the application of this to some types of facilities, such as yes, non-acute hospitals, long-term care. So they're not in this.
We'll speak to that on the next slide, but
Great.
Great. Okay. So yes, on this topic of cost not included in what we just saw, we've mentioned the emergency departments, which we do not have an estimate for. Our outpatient departments are also affected by the mandate, and again, we do not have data that we were confident in to estimate an effect there, and observation units as well. As noted, there could be increases in costs to other types of hospitals. The patient we have in long-term care hospitals that are not included here, and there is again some ambiguity as to the application of the mandate to those. State agency implementation costs are not included, and any penalties for non-compliance are not included here. So I'll just stress again that the costs that I showed in the previous slide are ongoing annual costs. Other folks have thought about one-time costs that hospitals might incur in the beginning. Okay, so a little bit about that.
I just wanted to finish the point, Madam Undersecretary. There is some ambiguity in the drafting of the ballot initiative and its applicability to certain types of non-acute hospitals, rehabilitation hospitals, depending on their licensure. They are not included in this analysis, and I would say, as a disclaimer, the assumptions, everything that's built into this presentation this is a research presentation and is not determinative of how this commission may think about regulation development should the ballot initiative pass. We do have a role in implementing regulation. So I just want to make clear that this is we did not make these assumptions based on was based only on kind of our research questions, and matters of interpretation of the ballot initiative will best be left, should it pass, to the regulatory process.
But I think we can't lose sight of the discussion that Lois Johnson gave us. The Massachusetts proposal is far different than California in terms of the fact that in California you allow the regulatory process to take a hard look, to develop the ratios, to back and forth. There are clear statements about what the rules would be. As much as the discussion on California was interesting, I don't think we should overplay California. The rules of this one, for good or bad, we need to understand that, are far different. They're much stricter, they're much clearer, there are no, and so as much as we or anybody else would have an implementation role, you would be very much restricted, whoever does it, in terms of what you could and couldn't do. Or in California, they allowed much more flexibility on the part of the institutions, and allowed a regulatory process to decide on the rules. I suggest everybody take a hard look at the slides that Lois Johnson presented, because much as California is interesting, I always like that, I would not spend very much more time on California because the Massachusetts rules are quite different.
Great, just before we go on, Rick, I know you had a question previously. Did you want to raise it now?
I can wait, until Dave finishes. Okay, almost at the end. Yeah, okay. So I was noting some of the one-time costs that hospitals might incur, costs of developing, purchasing, and setting up these acuity tools. There could also be costs of recruitment and turnover resulting from a sudden burst of hiring of these new RNs. For example, if some of them are recruited away from other hospital jobs or other non-hospital jobs, those institutions might then have to backfill that position and incur a cost as well. We don't know how many that would be, but there would certainly be a cost associated when that happens. We have a slide here mentioning the situation in the emergency department where, though we did not include a quantitative estimate at this time, it's been a topic of some discussion. We want to at least speak to what might happen. The ratios are, as noted here, different according to the acuity of the level of the patient in the ED, and there could be impacts, a number of impacts depending on how these are implemented and how they're followed. It could impact access to emergency care, they could impact wait times, they could impact patient flow in the ED, the subject of ED boarding, whereby patients might stay in the ED for a long time waiting for a placement in another institution, and diversion of ambulances. And again, we don't know enough to be able to project an impact on either side of how those outcomes would be affected. We also wanted to include, if the research was strong enough and we felt that it was, to at least speak to potential cost savings. There is an abundant literature noting the relationship between levels of staffing and patient outcomes. And in one notable paper from 2006, researchers estimated that an increase in staffing of the order of the levels that we expect would be associated with some cost savings, mainly from reduced hospital length of stay and reduced adverse events. So the savings would be in the magnitude of this range, which we're showing here, about $34 to $47 million extrapolating from those studies. But we did not include them in our formal estimate, and we note that it is not obvious that we would reap those savings from the increases that are required from a mandate. As Joanne mentioned, the differences between well-staffed and lower-staffed hospitals aren't necessarily the same as if what would happen in a mandate when an increase in staffing is required. So that is why we're noting those on this slide here. There could also be savings from reduced RN turnover due to the greater levels of staffing and reduced workplace injuries. And that is also the literature on those studies is cited here, and you can see them in the back of this presentation.
David, in the prior slide, when you were talking about the costs of recruiting and orienting new nurses, the range 38 to 60 plus thousand, is that per year per hospital or per year per nurse?
That is not per year, but it would be a one-time cost, so it's per
one-time cost per nurse.
Per nurse, that's right. But the uncertainty there is the number of nurses for which that would occur. And the next slide speaks to that. So, starting with our estimate of the number of newly required nurses of about 2,000 to 3,000, it's unclear. There's a number of sources where hospitals might get those nurses. And again, the turnover estimate is dependent on where they come from. Some of them might be recruited from other positions in the state, in hospitals and outside of hospitals. Hospitals also tend to make use of temporary or traveling RNs to fill needs, and in California, there's anecdotal evidence that that was an initial source of new RNs. There are also ways to increase your workforce without hiring new RNs, such as RNs could increase their hours worked, they could shift from part-time to full-time, they could put off retirement, say with the right incentive, and so on. So we expect all of these mechanisms to be in play. And finally, a note about, given the additional workforce needs, where do we think we are in Massachusetts with respect to how easy or how difficult it might be to increase the registered nurse workforce? We know a little bit about this from a couple of recent analyses. One was by the Department of Health and Human Services, a subdivision called HRSA, which is in the business of projecting nursing shortages. And they did a projection a few years ago, state by state, finding that they felt that the nursing workforce by the year 2030 would be quite abundant. And they projected surpluses on the order of 20 to 30%, as you see here in some states. And on the Massachusetts, in this analysis, was towards the low end of one of the least abundant workforces expected by the year 2030, though they did project a very small surplus for Massachusetts. A different study, looking at something similar, but here breaking down the country into 9 regions, found that compared to the other regions in the country, nurses in New England had the slowest growth between 2009 and 2014 in terms of total workforce numbers, and the slowest projected growth out to the year 2030. Massachusetts, by the way, is about half of all New England RNs. And that slower growth in New England was due to a difference in the age distribution of nurses mainly. But New England had the oldest nurses in the country, with almost half at age 50 or over, as you see on that left bottom graph, and the smallest percentage that are under age 40. So there's a lot of retirements coming, a tighter workforce, and slower expected growth. Okay, so finally, how do we understand this bottom line of the dollars of impact that we showed before? What would hospitals do when faced with such a cost increase? As David Cutler noted, it would be differential across hospitals, and there would be different responses. Hospitals could try to absorb those costs. They could do a number of things. They could just face reduced margins, which one study in California did find that hospital margins dropped with the implementation of the mandate. They could reduce capital investments. They might close unprofitable or other service lines to make up for the difference. They might reduce other non-healthcare workforce to make up for the costs. As Joanne noted, they might also, if they cannot absorb these costs, they might attempt to negotiate higher reimbursement rates from commercial payers. If they were able to successfully do that, that could lead to higher premiums. And again, we do not know to what extent each of these mechanisms would be in play. It depends on a lot of things in the market. But taking those total cost estimates by themselves, that represents about 1.1 to 1.6% of total healthcare spending in the state. And that is that's the benchmark of $61.1 billion in 2017. So that's a substantial amount. And if you look at that in terms of, from the hospital point of view, dividing the total hospital cost by the total hospital spend or hospital expenses in the year, it represents about 2.4 to 3.5% for our low and high estimate of total hospital spending in 2017. Okay, I'll turn it over to Dave. I also take questions for sure.
Okay, let's take questions and we will try to wrap up, let's say, by 11:30. I'd ask commissioners especially to think about questions that we might be able to answer before the cost trends hearings. So if there are things that came up in any of the presentations that you'd like more information about or that you feel are unanswered but answerable, let's focus on those as well. So Rick, you're up first.
Great, thank you, Wendy. I guess I had 2 observations and a question. One, I, like David Cutler, was very concerned about the chart where you showed the impact on community hospitals, particularly those with high public payer mix, the dramatic increase in spending that they'll need. And I mean, they already have a hard time filling positions. You hear that a lot, and particularly outside of the greater Boston area. I'm on my way to Springfield after this meeting, and you hear that about from those hospitals out there, how difficult it is for them to fill their existing jobs, let alone meet these new staffing ratios. So I think it poses a particular challenge for those types of facilities. I guess I didn't realize that the ballot question said these ratios are in place at all times. So I don't know how hospitals can plan for that since they really can't control their census, particularly in places like the ERs. So just boggles my mind how they would be able to meet the requirements of the law. And then I guess my question is, Dr. Spence noted that in California, the law was passed and 5 years later implemented. This ballot question requires implementation in less than 2 months. Is that right? And did you look at the feasibility of that, which seems to me that would be totally impossible for hospitals to meet?
we did not include that as a factor in our analysis, but it may be something that would be a perfect topic of conversation at the cost trends hearing with our panel.
This was primarily in just understanding the importance of the comments that are being made about practicality and impact. This is primarily a study about the cost of implementation.
Yeah.
So we needed to stop there in terms of our mandate. Okay.
One other comment to note that most hospitals do currently have mechanisms to accommodate surges in patient flow, such as float nurses or per diem nurses that they use. But our estimates account for that and see what would be required above and beyond what they do today. That's an important thing to know.
Thank you.
Yes, Tim.
So first, thanks to the committee for allowing me to crash the party today, because I'm not a committee member here, but clearly this is an important issue. As a representative of the healthcare workers, workforce on this commission, taking responsibility seriously, and it's an important discussion to continue to have. And I think given the time and the 30 minutes overtime that already are, I think it's there's a lot of questions that remain about the overall impact of the ballot question. Clearly, there's now a third major data point that's being put forth around what the implications and impact could be of the ballot question. And so I just think that I think it's really important that we had this conversation. I think it's great that the Health Policy Commission put this out well in advance of the cost trends hearings and the comments made by you, David, at the beginning of this, to give both sides an opportunity to see where there's disagreements or where they have some additional information that can help further this conversation and get that information out between now and the final presentation that's at the cost trends hearings. I think it's going to be a robust conversation at that cost trends hearings. I think having a response panel to this and kind of digging into some of these questions, I think is going to be really important. I think really better understanding the projections around what the rate of increase for the workforce would be in terms of their salaries. I think it's one of the big ones. And one thing that I took away from the earlier presentation was just about the 0 to 8% with an average of 4, and how does that break down across some of the impacts of the systems, right? I keep looking back to the slide of the impact by provider type, and there's going to be different impacts for folks based on how many shifts they currently have covered and what the increases may or may not need to be, but there's also different rates of pay in those institutions as well. So to take some of those things into consideration and saying, based upon this analysis around how they may directly or indirectly impact some of the different provider types, I think would be important, but also taking into consideration the different rates of pay that are provided in those institutions. And I would ask, particularly around one of the ways in which providers may implement this change is reducing the workforce, to put that in the slide when clearly the potential, if it were to pass, states that cannot in fact happen, and that is something that as the representative here of the healthcare workforce, we're really going to have to take into consideration that if the implication is that institutions are going to lay off the direct care workforce outside the RNs, I would state unequivocally that the law says you cannot do that. And so I just think taking that off as something that they can do would be important, because that is something that's in the law that they cannot do. Clearly, there are going to be lots of ways around that, but we're going to remain diligent, make sure that those unintended and consequences don't occur. So a lot to continue to digest, lots of questions to bring forth, and I think it's going to be a really good discussion. Again, I think it's important that there was some time to now in the hearing to have folks poke holes as much as they want. That's what we want, a transparent, open process, and have a fun conversation at the cost trends hearing and continue this important discussion. So thanks for the opportunity to be here today.
Thank you, Commissioner. I just want to respond really quickly on that slide. I think we specifically use the words reductions in non-healthcare workforce because of the protection on reductions in the healthcare workforce, which is a term in the initiative. So that wasn't to clarify that point.
Stuart.
Yeah, let me.
Stuart, could you bring your microphone just a little bit closer?
Let me first echo what David and others have said. David Arbach and your team did an extremely good, thorough job, and I think we all benefit from this. I do want to comment, Tim. Yes, you can substitute, but it doesn't stop institutions from closing units. And one of the things that I've learned being an economist as long as I am, one of the things you need to be are what we call the unintended consequences of events. And it's inconceivable to me in this environment, knowing that there are some services that are, unfortunately, money loses services that we need, like behavioral health, and as you pointed out in Lowen. So it doesn't stop an institution from closing a unit, and they're indirectly significantly impacting on the employment of both RNs and non-RNs. So, you know, as we think about this, we need to take that, could not be may turn out to be more than a trivial issue.
Excellent point. Any other questions or comments? Okay, great. Just let me add my thanks and incredible appreciation, David, to you, to Lois, to Kate, to Hannah, your entire team, and Joanne as well. Thank you for joining us on the phone. This was an extraordinary piece of work in a very short time. And I think I would go back to Stuart's earlier comment. The two slides that Lois presented bear a lot of attention for the commissioners because they are a terrific summary of where we have leeway in terms of regulations should this initiative pass and where we do not. So thank you all of you again, and I'll turn it over to David Sells to finish up.
Just one final note, this presentation is available on our website. And I did mention before, for those of you who do want to provide comments or feedback to us in preparation for the cost trends hearings, would ask that you contact us, and the point of contact is going to be Colleen Elstemeyer, our Deputy Executive Director, who's going to be point of contact for that. So please reach out, and we're interested in your feedback, and hope to see you at the cost trends hearings. Thank you.
I'll see you soon. Good to be in. Yeah. All right, I'll see you there.
Thank you.